I'm Sree Srinivasan, and it's my pleasure to talk to you once again about various issues in our lives. And today we're going to talk about health, mine, yours, everybody's. And we have a fantastic guest who is here with us and is going to help us understand the situation, what is the latest in health research around diabetes, cardiovascular disease, and so much more. Please welcome Dr. Alka Kanaya. She is joining us from San Francisco. Hi, Doc.
Hello, nice to be here.
Nice to be here with you. I know we had some fun with the technology. It just shows you that you can be as tech savvy as anyone and still run into things. I saw that Substack made some changes at the last minute, but I'm so glad you're here, taking time out.
Sure.
Is this vacation or is this a work day? Where
It's
are
a
we?
day,
It's
deep inside a work day with grants and papers and all coming at me. So yeah.
Okay, well, so then even more special that you joined us. We have people watching from around the world coming in. We're so grateful to everyone here. Please ask your questions. This is a chance to learn from one of the best people in the world to teach us all the important things that are happening around various aspects of health. And she is, among other things, the person who helped make possible the masala study. It is not a word, it is an acronym. It's become a word, an important word in the health field, and it stands for the mediators of atherosclerosis in South Asians living in America, the masala study. And this is the first longitudinal study in the US of South Asians to understand what factors lead to heart disease and guide prevention and treatment of heart disease. Such an important study, 16 years. If you could, please set the stage for us about discover, measure, prevent, discover heart disease risk factors for South Asian Americans, measure the early stages of heart disease to learn how it develops, and prevent heart disease by sharing findings with researchers and community.
Yeah. No, thank you. Yes, so we've been doing this South Asian cohort now in the US for 16 years, as you said. It started out as a pilot study that started 20 years ago. And with that pilot study, we recruited 150 Asian Indians who were living in the Bay Area and partnered with another ongoing study called MESA, the Multi-Ethnic Study of Atherosclerosis, which is a very large US NIH-funded study that has 4 different race ethnic groups, population groups, whites, blacks, Latinos, and Chinese Americans. And we wanted to see whether the South Asian individual, the phenotype of South Asians was similar or different or, in between some of the other population groups. And so the discovery has been that the South Asian ancestry group is very different. It's very distinct in terms of risk factors and the progression of disease. And we've been looking at many factors that cause the progression of atherosclerosis, which is hardening of the arteries that can lead to early heart attacks. And the real reason we're doing this is to figure out what can be modified, what can be prevented, what factors can be mitigated to improve health. And what we learn in South Asians is relevant because not only are South Asians 23% of the global population, but it also tells us about the heterogeneity, the diversity of different human biology that exists. And, this biology can be seen in all groups. It just may vary in terms of the distribution of how much you see certain types of factors in one group versus another.
And if you could give us a little bit of background in how you came to set this up
Yeah.
and the funding, how does all that work? And it sounds so important.
Yeah.
For us, for those of us on the outside, this is such an important topic, but we don't know enough about it, and that's why we need your help.
Yeah. So, I'm an internist. I'm a physician scientist at UCSF. I did, my medical training at UCSF, my residency in internal medicine, and then I did some additional fellowship training in research, in how to conduct research on human populations. What's ethical? How do you ask a question? How do you put together a research study that is done in a very, scientifically rigorous way? and can be replicated to find the same results. And so with that training, you apply to usually NIH is the biggest funder of scientific research in the United States. And it took 5 tries for me to
Mhm.
get the first pilot study, as I mentioned, in 2006, funded to really understand this group. And that reason to do that work is personal to me because I come from this community and I just looked around me in my family and in my community to find that there's a lot of diabetes and heart disease. There's people having heart disease in their 40s and 50s, and that's different. And when I'm a primary care doctor and I take care of patients from all backgrounds, right? And when you see one group that's more adversely affected, having earlier onset of diabetes, hypertension, heart disease, you kind of stop and say, what's going on here? Is there some genetic factor, biological factor, social factor, structural factor? What is happening? And that was really the crux. And when I dug into the literature from around the world, people had been doing small studies like in the UK and Canada and Singapore, finding similar things that there's a higher prevalence of heart disease and diabetes in South Asians who have migrated from the South Asian subcontinent to these other areas. And these people are having more aggressive heart disease than the other populations there. And no one had really answered that question of why. And so this was the opportunity to do something scientifically rigorous to answer a question that could help to fill some of these gaps. And that's the whole premise of science is ask a question based on your observations. And I was seeing my observations in my family, in my community, in my patients, and then answer the questions with a scientifically rigorous study. And the study design of Masala is a longitudinal cohort, much like the Framingham study, which many of your listeners may be aware of. This was a big study started after World War II in the 1950s in Framingham, Massachusetts, where they followed a whole community of people, mostly, white Americans, and they've been following these people and their kids and their grandkids now for 65 years. And that Framingham study is really kind of what started this whole revolution of cardiovascular risk factors and knowing what causes heart disease in the future by following people and being able to do statistical analysis and modeling of risk factors.
That is so special that you were able to work on that. You said it took you 5 attempts to do that, and that's partly because I'm sure that maybe how science works is they don't want necessarily to be going into smaller and smaller populations. Could that be a reason why it took so long? One of the factors?
Yeah, no, it's a really good question. And, this was back in when I first started writing grants. I had just, finished my fellowship. So it was early 2000s, very different generation of research back then. There were other priorities, in terms of what was happening in the US, and funding pay lines were not as robust after 9/11. There were things that were happening that needed other funding streams. So it was hard to get a grant when I was writing these first grants. The pay lines at the NIH were in the 8, 9, 10% back then for a few years. And so, that means 90% of grants don't get funded. And
Mm.
so most people to get any kind of grants funded, need to apply 2 to 3 times. I think for me, as a new person applying, not being savvy and not having as much of a robust background with research in terms of my own productivity to date, it took a while for me to get there and to convince the reviewers that this was a really important subpopulation of the United States that required, more thinking, because I had to make the case of what are we going to learn in South Asians that apply to the average American? Why do we need to study South Asians?
Mhm.
Why are we going to learn anything that is important for other people? Or why does this even matter? South Asians at the time were, only 1.5% of the US population, and currently they're 2% of the US population, but they're 23% of the world's population. So there's many ways that I had to finesse the story to make the story something that was important.
Thank you for doing that and making sure that happened. Folks, we're looking at the Twitter handle for masala_study. And if you go in there, you will be able to see some of the things that they're doing. Please follow masala_study. We want to take your questions. Please start typing them in the chat. We will bring them to you to the doctor who will answer them. And please know that all of the things we're talking about affect everyone, not just South Asians. So you might be South Asian, you might have friends who are South Asian, but this matters to everyone. And I want to just remind people why I'm doing this and why I care so much about this. I was diagnosed, Doc, with pre-diabetes. And so I started this section of my Substack and a WhatsApp group, My Pre-Diabetic Life. I'm a guy who could eat that entire bottle of Nutella, not just a regular bottle of Nutella at a single sitting. So could a guy who has never skipped dessert prevent diabetes? That was kind of the basic question. And I saw my dad who'd skipped dessert for 75 years, injecting himself one morning. And that's when I said, oh my God, if he's gotten diabetes, then I have no hope. So this was a wake-up call. Do you find that people have these kind of moments? They may not go out and start a Substack, but do they have these kind of moments?
Yeah, it's the come to Jesus moment, the wake up call moment. Yeah, no, I mean it takes different things for different people, but when it hits close to home, like you said,
Yeah.
seeing your father, and for many people, it's like seeing someone they love have some outcome, some health issue that is totally not expected or came out of the blue. That can be the wake up call.
And this is, I was told, one of the only diagnoses a middle-aged man can get that is reversible. So let's try, and don't give up is sort of the point. Partly, I think there's so much sweets built into kind of the Indian diet in many cultures around India. I think that's part of it. And then I just had a very natural sweet tooth. But somebody joked when they saw me starting, they said, aren't all Indians pre-diabetic?
I guess at some age that happens to a majority of people, but it doesn't have to be that way. And it certainly wasn't that way generations ago. Things have definitely accelerated to having, India being kind of the epicenter, not even India, all of South Asia, really the epicenter of the diabetes epidemic, if you want to call it that. Yes.
We have some great folks watching. We appreciate you being here. What we will be doing is taking this video and putting it out on our Substack, on our social media, sending it out around the world. And so please ask questions of Dr. Alka. We'll have her answer some of those questions. So I have a few, and then we'll go to the audience. Very specifically, when I have the opportunity to hear you present at the Arogya World study and conference in California, one of the things you brought up was that the BMI number that is now part of the culture, the vocabulary of health in America, something like 20, you'll tell us it's something like 26 is the number that we're all told means you're obese or heading that way. You said something very dramatic to me. You said that's incorrect for South Asians. It needs to be lower. I was hoping you were going to say it's higher. You said it's lower because I'm fighting that 26 number. So please tell me more.
Yeah, so where BMI origin story is interesting. So, BMI comes from several large studies that were done around the world looking at what measure of body size predicts who is going to die early or not. And so they've done lots of different fancy models looking at what is an appropriate BMI cut point for when someone's overweight, when someone's obese, when someone's normal weight, and it varies. So Asian populations from anywhere in Asia, including the South Asian subcontinent, Asian people have smaller body sizes and body frames than people from other parts of the world. And so the cut points that have been used and recommended by large, Lancet and WHO commissions are a lower BMI cut point for overweight starts at 23 to 27.5, and obese is 27.5 and above. Whereas for all other populations, overweight starts at 25 to 30, and 30 and over has been called obese. Now, BMI is a surrogate marker of obesity, and it doesn't work so great in terms of really predicting who's going to go on and develop diabetes, who's going to go on and develop heart disease, because again, it's a measure of your weight on a weighing scale and your height, and a mathematical formula. And if you are, you know, one of the few people who has a lot more muscle mass than fat mass, you're going to have a very high BMI, but it's not because you have a lot of fat mass. It's because the muscle weighs a lot more. In the average person, there isn't more muscle than fat mass, so it tends to work a little better. But, there's a lot of problems with BMI and in South Asians, and that's what we found in our study, that the BMI, that even at normal BMI, which would be under 23 for Asian groups, there's a lot of metabolic abnormalities. There's a lot more diabetes or prediabetes. There's a lot more abnormal cholesterol, high triglycerides, low HDL. There's a lot more high blood pressure. And so, what we have shown in our study is that using BMI as a criterion for who should get screened for diabetes, that's the current standard across the US based on guidelines from the American Diabetes Association, the US Preventative Service Task Force, that using the cut points of overweight you miss about 40% of Asian individuals. And so we really worked with ADA to lower the cut point to 23, but honestly, for South Asians, the cut point is more like 19.6 when you start seeing this inflection of lots more metabolic disease. So BMI itself should not be used as a criterion for saying who's at risk for something when there isn't a great cut point. There's high risk even at low BMI. So the question is, what is going on here if you can't rely on BMI at all? And this is not unique to South Asians. I want to make the point that in every group, there are people below that overweight BMI that have high risk. And it's just much more common in South Asians. It's almost 1 out of 2 South Asians in that normal BMI group have metabolic abnormalities, when it may be 1 out of 5 or 1 out of 8, other like Latino people or Chinese people or, ancestry groups. So it's just super common in South Asians. So we see it a lot more.
Folks, we have about 25 minutes left with Dr. Alka Kanaya. We're so grateful to her for being here. She's scaring us right now, those of us who are South Asian. So let's take a look at my health status, Doc, from Q1. You can see I'm age 55.5. And by the way, my wife said, isn't there any HIPAA considerations here? I said, it's my own information, so I think I'm allowed to share that. So here's what I wrote. And so I said in January, I was 198.1 pounds, 28.3 BMI, and my body age was 58. Thanks to this diagnosis and all the effort I put in and learning from Arogya World and some luck, I've brought it down. I'm now have to go back and check. And you see, my BMI is 26.5. It said I'm no longer obese. I'm muscular overweight is the term it used. That's certainly slightly more flattering than the other one. But you're saying this is all not enough, that needs to go much lower to be truly safe and healthy.
Yeah, well, see, I think if you're just relying on BMI, then yes, the BMI is still high. But again, if your BMI is more muscle than fat, then that is actually a good thing. And BMI is just not enough of a marker to tell that apart, right? And so you probably, with the healthy changes you made in January, you lost some weight. You may have actually done some resistance training and improved your protein intake to actually build more muscle mass. And so if that's the case, then that BMI of 26 is good. It's telling us that you have extra weight that may be coming from muscle. It can't tell it apart. So what is going to be important is to look at what's happening to your A1C, what's happening to your glucose levels. And so that'd be the next question for you.
Sure. Let's see a question here from Jeremy Kaplan. Beyond BMI, what about A1C levels that you just said and their significance? Curious about your takes or your thoughts on how feasible it is to reduce A1C number of 5.7 or up, and whether that is a significant way of thinking about measuring reduction in likelihood to develop diabetes. So he's echoing something that I think about all the time.
Yeah, no, that should be the metric that you're looking at when you're working on prevention of diabetes is how much is my hemoglobin A1C improving? How much is my fasting glucose improving? Because those are where you wanna get it down into the low normal range, right? So, getting it below 5.7 is wonderful, and that is the goal. So, uh, you don't have to focus as much on weight as much as you need to focus on what's going on with the actual glucose levels in your body. Now, hemoglobin A1C is interesting, and I do want to say that it can be deceiving in certain groups. And what we found in South Asians, there's more thalassemia. There's more vitamin deficiency, especially vitamin B12 deficiency. There may be anemia from iron deficiency as and so hemoglobin A1C is, all it is your hemoglobin protein that carries oxygen around that is glycosylated with extra glucose because there's extra glucose in your bloodstream that's not being taken up into the muscle and organs. And so it's a marker of how much glucose is extra in your bloodstream. And people who have anemias and thalassemias may actually have an elevated hemoglobin A1C level. So it's something for you to, be careful about because we've shown that in South Asians that you can get this falsely elevated hemoglobin A1C and not to over rely on that for the diagnosis of diabetes, prediabetes to make sure that you're getting, you're triangulating the data with a fasting glucose that's high or a 2-hour glucose tolerance test that's high and don't only rely on a hemoglobin A1C.
Okay, that's very helpful. We're looking right now at some of your results of the findings from the Masala study. Can you just talk about those, please?
Yeah, I mean, we've published over 150 papers, and we blog about a few of them, just to keep it light and fresh. Like the newest findings, we write short blogs about. But you can see all of the published papers on our website as well. There's many findings. Why is there so much diabetes? What we've done is use CT scans to look at where body fat is deposited. In general, body fat should be deposited under the skin. So that's, subcutaneous fat. That's our old website. You probably don't want to look at
Okay.
that one.
Okay. Sorry.
Yeah, you want to go to the newer looking one.
Yeah.
And so we found that South Asians store more fat in ectopic areas where it shouldn't be stored. Like there's more fat stored in the liver. There's more fat stored around the visceral abdominal organs or visceral fat around the intestines. There's more fat stored in the muscle. And when you have fat storage in places where it's not supposed to be, that can lead to more disturbance in the system and a quicker transition to becoming diabetic.
And so, folks, please check out masalastudy.org. That's the website, www.masalastudy.org. And you can see all the research papers they put up, what they've blogged about. You can see of the events that they're having. Can people still sign up to be part of this?
Unfortunately, no. We had enough funding to expand our study, and until last year, we have a total of 2,300 plus participants in the study now. We have people with origins from India, Pakistan, Bangladesh well represented in the study. And unfortunately, we just don't have any more funding to keep adding people at this time. We hope in the future, if we are able to garner new funding, we'll be able to open up new sites. Masala is running now at my site, that's UCSF, as well as Northwestern University in Chicago, and the third site is New York University.
Excellent. Give you a chance to give a shout out to some of your colleagues.
Yeah, these are people at UCSF who've been with me from the almost the beginning of the study. They help retain our participants at our UCSF site by reaching out to them and having them answer questions every year. Once someone has a heart attack or any kind of hospitalization, we ask them to share their hospital records with us so we can see what happened exactly. And the whole point of the study is to take the rich data that we collect when we see people every 5 years and correlate that to who goes on to develop a stroke or a heart attack or heart failure. So that's UCSF, and the next people below is from Northwestern Chicago, and then that these team members have been with the study for 10 years. And New York University is the newest site that we started in 2021. So, and we're so happy to bring the New York staff and investigators into the study. And they helped us recruit the newest wave of immigrants who are Bangladeshi and Pakistani into the Masala study, which originally started out with being 85% Indians. And now we have this diversity of South Asian groups, which is great because we are so interested in learning about the differences in risk profiles between these three large South Asian subgroups, finding that actually Bangladeshis have the highest risk. They have almost 50% with diabetes compared to 24% of Indians who have diabetes. And Pakistanis are in the middle with about 41% with diabetes. So unless you disaggregate the data and look at the data by, ethnic origin group, you really don't, that you put them all together, you just get an average of all of the groups, right? And so disaggregating this has been really important because, culturally there are differences in how people eat and how they live in their social situations, in their family situations. And we have to be able to implement interventions that can be tailored for each group.
Thank you. Folks, we have about 20 minutes left with Dr. Kanaya. We're so grateful to her for having her be with us here. Doc, do you do any social digital media yourself, or is it all back to the USCSF?
Oh gosh, do I do social digital media?
Yeah, yeah.
Yeah, well, I mean, Masala has a Twitter
No, of
feed, and
course.
it has,
Yeah.
I mean,
Okay.
X, and
Yeah.
but in terms of reaching out to people, I'm
Mm-hmm.
happy. I've done tons of different webinars and
Mm-hmm.
podcasts and and we're always happy to do more. To find time to give back to the community. Just last week, it depends on the group. Like I spoke to senior citizens at the India Community Center and gave a talk that was live in person with over 100 people who just want to hear what's going on with dementia in groups that have so much diabetes. Yeah, of
Thank you for going out into the community and speaking to
course.
everyone. Liz has a question. Would waist to hip ratio be more helpful than BMI? And can you explain what that is too?
Yeah, so waist to hip is basically a measurement of your waist circumference taken at the level of the belly button, and hip circumference is kind of taken at the level of the hip, the broadest area of hip. And this is a ratio. It is extremely hard to do accurately, and it's not done in the clinic for that reason. It doesn't take much for you to suck in your breath to actually move your waist circumference by 2 centimeters, and waist to hip, it takes a lot more time and expertise to do it correctly. If we do it in research studies, we do find that waist circumference or waist to hip ratio is a better predictor of diabetes and events than BMI, certainly. But it's not something that's easy to translate into real life because, again, the measurement is complicated and hard to do well.
And by waist, do you mean including the belly? Because most waists are not that big, are they? Is it the
They
belly or the waist? Is it together? I'm sorry that I don't know.
At the level of the umbilicus, so if you go around,
Okay.
that's the waist circumference. So, I mean, that is the problem with, like, people who store fat in their abdomens, that you have more of an
Mhm.
apple-shaped body, and so the
Yeah.
waist circumference will be much bigger than the hip circumference, and the apple-shaped body type has been well known and described since the '70s, right? That people who are apple-shaped tend to have more problems with diabetes and heart disease than pear-shaped. Pear-shaped is people who store fat in their buttocks and in their hips, and that is actually subcutaneous fat, the fat that is a little bit healthier to store. So it's
So wait
getting
a
to the
minute.
same thing.
Yeah, but the pear shape is the in popular imagination. That's like when something's gone bad, we say it's gone pear shape. But you're saying the apple shape is worse than the pear shape.
Yeah, actually it is. So men, have more of an apple-shaped body. Women have more of a pear-shaped body. After menopause, women redistribute their fat and become more apple-shaped. there's much more fat that's now stored in the middle rather than in the gluteofemoral areas. So women notice that, and you can actually measure this, and it's been done in studies where the waist circumference goes up after menopause because estrogen helps determine where body fat is stored. So yeah, so apple
Mhm.
shapes are unfortunately higher risk. Yeah.
Women can catch a break, isn't it?
Yeah.
You have this issue, and then after menopause, here's something more to look forward to.
Yeah.
Alas,
Become,
uh,
yeah.
yeah. Let's go through those numbers again. You said Indians at what percentage, Pakistanis what number, and
Yeah.
Bangladeshis at what number?
This is the diabetes prevalence in our
Mm, mm,
study. So what we found just recently, because we expanded the study to include 600 Pakistani, 600 Bangladeshi, there's 900 Indians already in the study. We found the Bangladeshis had the highest prevalence, almost 1 out of 2. So it's 50%
mm.
of Bangladeshis in our study have
40
diabetes.
something and then 20 something. Is that correct?
Yeah,
Is that the number?
41 for Pakistani and 24% for Indian. So 1 out of 4 Indians had diabetes.
And that doesn't count pre-diabetes, right? That counts
That's
people who
yeah,
have actually. So
and
we're
pre-di
talking an enormous number.
enormous number. And the question is, well, why? There, these these boundaries of Bangladesh, Pakistan, India are fairly new. If you know the
Hmm.
history of that
Sure.
subcontinent, Bangladesh really became a country in 1972,
Hmm.
Pakistan in 1947. And so there's a lot more similarity in the genetics of people who live across the northern part of India, Pakistan, and Bangladesh.
Hmm.
There's certainly
Hmm.
differences in southern India and Sri
Hmm.
Lanka. And there's definitely, different genetic waves of migration have affected, northern parts differently from the southern parts. But why is there this like very clear cut difference in risk across the north, those three north groups is that's and we are digging into this a little deeper to understand, is it social, is it immigration factors, is it dietary, cultural, is it other things in terms of stress levels, is it structural because people have to work 3 jobs to make ends meet, they're supporting bigger families, and so they're not sleeping as well, they're not getting health care needs met. So there's a lot of levels of possible risk that we need to understand. But our hypothesis is that there are going to be social, behavioral, and cultural reasons explaining these differences, that these are not necessarily biological reasons that why there's such a big gap between the three.
And it could also be different in South Asia versus living abroad. Is that
Yes, we've been
fact?
comparing our data
Mhm.
now in Masala to a contemporary study happening in India. And what we
Mhm.
found is actually very striking. For the first time, we're seeing higher prevalence of diabetes in India than in the immigrants who are in the United States in our
First
study.
time. Okay.
So in older studies, that whenever people migrated out of South Asia and went to the UK or Singapore or South Africa, all the earlier waves of immigration out of South Asia, that wherever those Indian immigrants ended up, they had more diabetes than back home, right? So
Mm.
compared to native Indians in the rural or urban areas,
Mm.
but now we're seeing this flip with
But
more, and that's why I'm saying it's like the epicenter of this diabetes problem now.
sure. Folks, we have about 10 minutes left with Dr. Kanaya. Please post your questions. And I see some questions there already, but I just want to make an observation. In South India, in Kerala, we've been told that there's a very high prevalence of diabetes. And
Yep,
that in Kerala, it's something, these numbers are just directional, but something like 20% in
yep,
Kerala, 18% in Tamil Nadu, which are two
yep,
relatively well-developed states compared to other parts. And Bihar, it's less
yes,
than 10%.
yep,
And so they by shorthand, some people say it's a rich person's
exactly.
disease. Is that true? Is that
Yeah, yeah, and that's exactly what has been seen in India in this really nice study that's called the INDIAB study, where they've sampled people from all 27 states of India, that the states that are economically advanced. So those 2 states in India that you
Mhm.
mentioned, as well as 2 states in North India. So that would be Himachal Pradesh and Punjab, I believe, the two more advanced states had the highest rates of diabetes, obesity, heart disease. And the relatively lower developed states, so economically still behind, had lower rates. So there is a globalization issue going on in terms of food and exercise and air pollution and the quality of your diet and ability to exercise outside, or the need to do manual labor. And so that this is so in India, diabetes has become more of a problem of, wealth, and the higher economic status groups have more diabetes than in the lower, but it's starting to change. So as each state,
Mhm.
develops more, you start seeing this happen. But then you come to, developed countries here, like the US and the UK and Canada, and you see the opposite, right? So the higher income people have lower rates of diabetes than lower income because of the quality of food and exercise and stress, and also healthcare that
Yeah.
they can afford, right? So
Mm.
that flip happens in the developed areas of the world, and I'm sure that flip will be happening in India as well.
I think there's also some research around blaming the arrival of satellite television and all these prepackaged foods
Yes,
that are
globalization.
spreading potato chips and all the stuff that you
Yeah.
sort of said under globalization. Okay, we're going to go to quick questions, quick answers. Shazia says, if South Asians at such low weight as BMI 19.5 are still at risk for developing diabetes,
Yeah.
how do we prevent their disease?
Yep.
After all, 18.5 and lower is underweight.
Yeah. So we don't rely on BMI, number one. Just BMI is not something that is the currency we should be talking about. We should actually be talking about the blood markers, like we talked about the hemoglobin A1C. We should be checking cholesterol levels. We should be checking lipoprotein A level, which is a independent risk factor for heart disease. And if things are high or in the pre-diabetes range, we need to be working on interventions to improve those numbers. And not all those interventions are about weight loss. Okay. And so I think that the key is about strength training and improving the quality of the diet to have more foods that have protein, but healthy sources of protein, healthy sources of nutrient intake that's less processed, and also, being able to use up the food that we eat, the calories we take in, because we have more muscle mass. What we found in masala was not only was there more ectopic fat, like I mentioned, in all of the places we shouldn't be storing fat, but that the South Asians in masala had the lowest lean muscle mass. So when you measure how much muscle there is in the body, South Asians have the lowest muscle mass compared to all of the other population groups in our comparator study called MESA. That means that, muscle building exercises needs to start early in life and continue through life. And that means healthy sources of protein to really build muscle mass. You have to use that protein to build muscle, and that's been found in studies done in South Asia, that parts of South Asia, especially the South India, has very high levels of carbohydrate intake. 65% of the diet is carbohydrates. So how do we start moving people to incorporating proteins into their diet, into their everyday diet? And I know there's this huge swing to proteins now, like it's all over media. Social media is all about protein intake. And I don't think people need to go wild. And I don't think you need you know, keto diet levels of protein. I think you need to have a balanced diet that takes in a lot of fiber rich foods, including fresh fruits, vegetables, whole grains, nuts, etc. And you need to make sure you're getting protein, especially if you're a vegetarian. And in India, there happens to be a lot of vegetarianism. About 25% of Indians are vegetarian. And so those people really do need to be more careful about getting adequate protein intake.
Sure. We just have a few more minutes with Dr. Kanaya. Please post your questions. I just want to do a shout out to the folks at arogyaworld.org, arogyaworld.org. They are working with me to help me understand my diabetes story, and they can help you as well. Please check out arogyaworld.org. And I know that conference was so interesting that I got to be at and then MC that dinner. And Dr. Alka was one of the stars of the conference. So many questions you had there, as we're seeing here as well. I want to ask a fun question. How excited were you when you discovered that you had masala could be made into an acronym?
That was a early in the morning, in the shower moment to come up with the name of the study. You know, sometimes my best ideas come in the shower. Um, yeah, so I mean, I really wanted when we started the study, it was really important to have a name that resonated with people that we wanted to be in our study, the people who represent, you know, the South Asian diaspora in the US. And so masala is a part masala means a mixture, and usually it's a mixture of spices, but it can be a
Mhm,
mixture of different vegetables too, right? It can be a mixture of things. And
mhm,
so that's why on the top of our page, when we redesigned our website, we have a
mhm.
picture of that's a mixture of different powders that could be
Mm.
considered a mixture of spices. But yeah, and so yeah, I worked hard to come up with that acronym, and I think it's nice because people recognize it as, you know, everyone knows what chicken tikka masala is, and even though that's not really a South Asian food, it was started in the UK, but, masala has become part of our normal vocabulary now.
Yes, yes, it has, and that's really cool that that has happened. Folks, please post your questions. What is your advice to people who aren't taking their diabetic diagnosis or their pre-diabetic diagnosis seriously? You are as you don't just do research. You're a clinician. You talk to patients every day. What are
Yeah.
the things that you're finding it hard to kind of cut through the clutter?
Yeah, yeah, yeah. I think people get overwhelmed with like, oh my God, there's so much I have to do to, you know, change my lifestyle, you know, improve my diet, exercise, sleep, stress, and it's overwhelming. But I think you have to break it down into what is feasible for you to do, what is your one goal, and take small steps towards that goal. But if your one goal is, I'm going to start doing some physical activity that's intentional every day, great. Let's work on that goal. Let's work on what do you think you can do? Do you think you can do 15 minutes in the morning and 15 minutes in the evening? Terrific. Let's do that. And then what's the next goal? And you know, breaking it down, there are so many diabetes prevention platforms available now, remotely, you know, in person, whatever works for you. I really tried to personalize this because you know, before I started Masala, I actually did a lifestyle program to look at the benefits of yoga in people with prediabetes. Um, and I think you can add yoga to your toolbox of ways in terms of prevention of diabetes. We found it. So we took people in this study. It was called the PRISM study. It's published. Um, and it was at two centers, and we enrolled people for a year-long yoga versus stretching program, and we found that people in the yoga group, which is restorative yoga, not exercise yoga, so very relaxation focused yoga, actually had improvements in their fasting glucose by 6 points in a year. They dropped from pre-diabetic to normal levels. And that's the same amount of improvement that we've seen in large studies like the diabetes prevention program, which is you know, exercise and diet intervention program. So yoga can be a nice additional way. So what there are so many tools in this toolbox for prevention of diabetes. So if you're if you're at a BMI of like 18.5 or 19.5, weight loss is not the lever you need to be pushing. You need to be making sure that you have enough adequate muscle mass even at that low BMI, eating proteins that are healthy, maybe incorporating different ways of stress reduction with yoga, with improvements in sleep. And yes, that question I see about adequate sleep and diabetes, it's absolutely important because studies have been done showing that people who don't sleep enough or sleep too much have higher rates of developing diabetes. So the sweet spot is between around 7 hours, but anywhere between 6.5 to 7.5 hours is the sweet spot of how much sleep seems to be adequate for a majority of humans.
Yeah, unfortunately, I'm never close to that, but I am monitoring it now more and trying to increase my sleep score. But seven seems such a luxury, and I'm going to aim for that. I want to remind folks that if you have WhatsApp right now on your phone, you want to pull that out, you can join my WhatsApp group. It's called Sree's Pre-Diabetic Life, and how we're using AI, social media, conversation tips, Arogya World, and great experts like Dr. Alka to help us understand and live with this in better ways, try to revise and review and improve our work. You, I'm sure, are working on other things apart from masala. If you want to talk a little bit about that, then we'll let you go.
Yeah, so I'm happy to be helping with a large study that just started last year called the Mosaic Study. It stands for um, wow, I'm blocking on
It's okay. Don't
multi-site
worry.
observational study of Asian American and Pacific Islander communities. That's what it stands for. And this is the first longitudinal cohort that includes many different Asian groups and Pacific Islander, Native Hawaiian groups to look at, again, chart the history and figure out what leads to disease. And that's because most of the longitudinal studies that exist in the US have not included these populations, just like South Asians weren't included, and that's the gap Masala tried to fill. But Mosaic includes Chinese, Filipino, Vietnamese, Korean, Indian, and Native Hawaiian Pacific Islanders. So there's 6 or 7 groups, and it's an 11,500 person study. It's in recruitment now. So if you know anyone who belongs to these background groups who lives in one of the Mosaic sites, Google Mosaic with its 2 A's, MOSAAIC, and tell your friends and family to join.
And these are they. You basically go in and they measure you, and then
Exactly. Yeah.
there's no it's not invasive in any way. It's just taking measurements, right?
It's
Yeah.
taking measurements, it's adding questionnaires, but then you're staying in the study and
Sure.
you commit to being in the study long term, just like in any longitudinal study where they reach out to you every 6 months for more,
Sure.
and you'd give blood tests, and a lot of things are optional, but when they get new studies like to look at the arteries in the heart, they offer you additional testing. So I hope that I put in a good plug for the Mosaic
Yes, you
study
have.
for you guys to check out the website, but it's recruiting in 5 areas in the US, and I'm happy to be a part of that.
I love that. In terms of where we go with all of this, is we need researchers like Dr. Alka to push the boundaries so that we can all learn. We have this idea that this stuff will just automatically get considered by the government. It is not true. And now we're seeing cutbacks in all kinds of government research grants
Yeah,
and things like that.
yeah.
Is it possible, Doc, that you could raise money to do more with Masala? And
Oh,
have you made an effort to do that? Where are all these Silicon Valley tech bros?
where are they? That's a good question. I've certainly tried to, make the case and the pitch
Mm,
to lots
mm,
of Silicon Valley
mhm,
types. We are grateful for any funding that we get. This has been an extremely challenging 2 years for
mm,
anyone doing
mm,
science in the
mm,
United
mhm,
States. Things are not coming through, and the government
mm,
has really slowed down in terms of both giving out grants as well as canceling grants. And one of our studies was canceled and was brought back after a lawsuit was successful. So,
mm.
yeah, we're always looking for people who are interested in supporting us. We can do so much more with the specimens we have saved. If Please reach out. Our website has a
Mm,
donor page where we
mm.
acknowledge our donors, and we have been fortunate to have a few people who've just been friends of Masala and donated, and to keep our lights on, especially during this really tough period.
If you have that number on at the top of your head, are we talking tens of thousands, hundreds of thousands, millions to make a difference in terms of what you're trying to do?
Yeah, no, I mean, our infrastructure costs are in the 500,000 per year kind of range, but
Sure.
what we can do with the biospecimens we've saved, I mean, we can do so much. If I could measure, vitamin D levels in everybody, that's $50,000, and it's like the
Mm,
$50,000 I just can't pull out of my bank account to do. And
mhm,
so
mm.
that's the kind of stuff is like we can take small gifts and put it together and measure something novel and be able to like inform the care of people with what we've saved. So we have many ways of using philanthropy to help, you know, accelerate the research we can do.
Well, we're going to write about this. We're going to make noise about it so that we can help people. Is there something like a trade organization for medical practitioners and researchers that is tracking grants that have been cut, maybe setting up support networks?
Yeah, this was happening all in the beginning when all the grants were being cut, and there were many, many scientists who were tracking this. But right now, many grants have been recovered. Like our grant was recovered
Mhm.
after the lawsuits were successful. There seems to be another new wave of grant cuts coming now, so I don't know what's being done. The HRQ is one funding agency that just had 45 to 50 grants cut, and people are tracking this. LinkedIn is a really good place to look for the people who are, really following this closely. Um, yeah.
Yeah. The last comment here. Mark Lee says, great show. Glad to hear you on this important issue. I have several friends who are diabetic, and Mark really pays a lot of attention to what's happening in the African American community. What advice would you give people in terms of diabetic support groups? Do they work?
Yeah.
And you've already given us some diet suggestions, which we will
Yeah.
ask people to rewind and watch or the replay. But if you have like top three things that you would tell people.
Yeah, so I think diabetic support groups are a great idea. I think it starts at home. So if you can get people in your community to belong to a support group of people with prediabetes or diabetes and who are trying to reverse their diabetes, I think that having someone to go through this with you and help you feel supported is so vitally important. Um, the thing I wanna leave your listeners with is there's so much more in our circle of control that in terms of prevention that I feel like, you know, that message doesn't come across, especially to South Asians when they see many people in their family and community being affected by diabetes and heart disease, is they feel like it's futile, like it's gonna happen. It's just a matter of time. And I just wanna upend that. I think that there's so much more that we can do to prevent these things than ever before. The knowledge is there. We just need to get motivated, find the support we need, use the data to track our own numbers, know them well, push back. If you go to our website on the health tips page, I just added a few more resources, and every week we add new resources under healthy diet tips. There's carb counting tools that are specific to South Asian diets because not all nutritionists know the foods that diabetic South Asians eat. So under
Wow.
nutrition,
Yeah.
you'll see, how to eat low carb as a vegan, how to eat vegetarian keto recipes. These are all, we're going to add a new South Asian nutrition guide. So please check out our website because we really try to tailor the information and refresh this information to keep it new and, updated.
That is fantastic. Doc, we're going to let you go. I'm going to do some housekeeping with our viewers. Thank you so much. Our guest has been Dr. Alka Kanaya, who is running the Masala study, is a doctor, researcher, and all around wonderful person, as you can see, donating her time and energy to this cause of saving the lives of her colleagues, her friends, her community, and Americans in general. So that is wonderful. Jonathan says, interesting program. Thank you. And we appreciate
Thank
you
you
very
all.
much, Doc. So we'll let you go. Thank
Thanks so
you.
much. Bye bye.
Yeah. Thank you, folks. Thank you so much for watching. I'm so grateful to Dr. Alka for being here. She can just X out and leave. We're seeing so many great comments coming in. Folks, tell us how you like this kind of show. Are you? There she is. She was able to leave. Thank you so much for being here. I'm actually on Long Island at a beach rental. I put on a good shirt for Dr. Alka. And I'm so grateful to all of you for watching. If you like this, we can do more of these. And this is part of my Sree Sunday Note and my pre-diabetic life subsection channel. I'm not sure what to call it. And what we are working on is helping not just me, but all of you who, if you know anyone who's diabetic, pre-diabetic, join me, join our WhatsApp group. That's the easiest way to kind of keep up with all of this stuff. And also, if you can, of course, support the Substack, we would appreciate it. You can become a member for $5 a month, $50 a year, or you can join my Patreon if you'd like that, we have some nice perks if you join the Patreon. And for those of you who've been paying attention and say, wait, Sree, you're doing various things. So this was on Substack. You do things on Zoom. That's right. We do Zoom virtual salons where only our paid members or people who support us in some way are able to ask questions of my very interesting friends on various topics. We still take all that material, put it to the general public. Every reader, everybody who signs up, whether they pay or not, get everything. But we have to give perks to the people who are able to support this kind of independent journalism. It means so much to me that you all participate, whether you just watch, you just read, you just share, all of it matters. Please be in touch. Sree@sree.net is my email address, Sree@sree.net. And I'm grateful to every single person who is here. I see so many great friends who've been here. I appreciate you very much. If you just joined, this will end. And then later this week, we will share what we have found here in a blog post, and the entire video will be available to you. We're always looking for guests. We're looking for speakers, and we would appreciate you spreading the word. And if anybody wants to join us to participate, we would love to have them. I do want to show you another series that we have launched, if you haven't seen it already, that you might like. We call it X Teaches Sree About Why. And what this means is we're able to do some fun things. This is a new series. Oops, sorry. This is from one of our previous things. Let me see if I can share it again properly. That was from our story about the Knicks, and was one of our friends' children had put together something that said, my mayor is Muslim, my bagel is Jewish, and Knicks in 5. That was what I was showing you there. But let me see if I can show you this here a little more clearly. X teaches Sree about why. So if you know someone who wants to teach me something, we'd love to have them. They can be, it can be you. If you want to nominate yourself to teach me something, here what we've already done. We had Andy Rich, who's a master seller and sales trainer, teach me how to learn how to sell things, because you have to sell in the 21st century ideas, products, services. And then Bobby Ghosh joined me to teach me about the World Cup and the beautiful game. And that was so much fun. You've seen him on MSNBC as well as MS Now. Dr. Leisure Carter is going to join me to teach me about food and health equity. And all of these are going to be, first, a virtual salon inside Zoom, invitation only to our paid members at sreenet.substack.com or patreon.com/Sreenet, SREENET. And then we put everything out so everybody gets it. We do not believe in not sharing all this useful information. We also have one coming up this week about the Odyssey, and I know you will love that because it is such a cool topic and so much to learn from that. So thank you so much, everybody, for watching. Jonathan says bagels are Polish. I had a friend who had bagels and hot dogs together. His company in Durham was called Bagel Dogs. And Pradya says such an important topic. Sree, is your kid still at Duke or have they graduated? They have, Mark. I came down to North Carolina a couple of times. I didn't see you, but I am back for JLF USA. All of you, I'm going to be in 7 cities in the fall. Let me pull up that list and then I will let you all go. We're going to be in 7 cities talking about the Jaipur Literature Festival and JLF USA. So let me just share that screen and that'll be the last thing we talk about so that we can let you go. And here you can see it. I'm going to be in 7 cities in 3 weeks in North Carolina, in Raleigh, Durham. We're going to be there September 11th to the 13th, LA 14th to the 16th, Seattle, Colorado, Denver, Boulder, Toronto, New York, Houston, and then the mother festival, that's the Jaipur Literature Festival, which Tina Brown called the greatest literary show on earth, will be there as well in Jaipur. So once in your life, you have to go there, but 25% of the US population is within driving distance of a JLF Lit Fest this fall. So no excuses. 2 hours, 20%, and 3 hours. That's 60 million people are within driving distance. And we do not just South Asian authors. In fact, in most cities, it's like 30 to 40% South Asian authors. It's folks, including South Asians who are very famous, as well as newcomers and people changing the literary scene. There's music, there's food, there's cinema, all kinds of topics, including political topics that are discussed. So thank you very much. Just go to JLF Litfest, follow JLF International on Instagram, and follow me, please, at SreeNet, SREENET on Instagram, and at Sree on Twitter. Pradnya says, so similar to Auntie Annie's, but bagels instead of pretzels, and let's catch up in September. Thank you, thank you, thank you, and many thanks to our friends at Arogya World for supporting this effort to teach me how to be healthier as I navigate this world. It's Arogya World. You can see the spelling right there, and arogyaworld.org. Thanks very much, everybody. We'll see you soon. Bye-bye.